we will discuss the management of deep bite. It is defined as the increased vertical overlapping between upper and lower incisors, which means overbite increase. It can be corrected by intrusion of the maxillary and mandibular anteriors and extrusion of the posteriors. Can be treated by removable orthodontic appliances that has an anterior bite plane like the Howley's retainer with an anterior bite plane that corrects the deep bite. Myofunctional appliances such as the activator and bionator with fixed orthodontic appliance can be used also. It is the main characteristic of the class 2 division 2 malocclusion. It can be due to skeletal genetic origin, where there is an upward and forward rotation of the mandible in the counterclockwise rotation. Also can be caused by a clockwise rotation of the maxilla or a combination of both. It causes decrease in the lower facial height. We can diagnose it by doing an orthodontic study model to evaluate the extent of the severity of the deep bite. We can do some cephalo images to evaluate the ramus height and the inter-incisal angle and Frankfurt mandibular plane angle. It can be corrected using an anterior bite plane with conjugation of the fixed mechanotherapy by adding acrylic on the maxilla behind the incisors so that the mandibular incisors touch the bite plane before the buccal teeth come into occlusion. So we are doing an early occlusion on the anterior portion where we are increasing the anterior intrusion and permitting the posterior extrusion. The activator can be used to correct the deep bite. We remove the interocclusal acrylic to facilitate the extrusion of the posteriors. The bionator and Frankel appliance can also be used in the management of the deep bite to correct the skeletal rotation of the mandible. We can use fixed appliances that are called the utility arches. These are, and they bring about correction of the deep bite by intrusion of the upper and lower anteriors and extrusion of the upper and lower posteriors, and they are getting the retention from the molar. The V-shaped activation part is on the premolar, where when we bend it and activate it, we get an intrusion force that is applied on the anterior incisors. Here another way that is common is called the arch wire with reverse curve of Spee, where the arch is exerting an intrusion force in this direction on the mandibular incisors to make intrusion of them. This is the arch utility arches. We can see them here, and this is the V-shaped on the eruptive premolar. It is transmitted to the anterior portion where intrusion takes place. This type of correction needs to be retained. So use a retainer that has an anterior bite plate for 4 to 6 months, and in these cases overcorrection is usually desirable, which means that to overcorrect the deep bite so we can get a shallow bite to an extent, to take into account that some relapse may happen to some degree, and we get at the end a equilibrium result that is sufficient and for the patient. That's it.